Good afternoon, everyone. Welcome to the first webinar in the Substance Use Disorders series. I'm your host, Susan Halpin. I'm sorry, there we go. I was having trouble. Okay, I'm the Education and Outreach Coordinator for the New England region of the National Network of Libraries of Medicine. I'm pleased to have Dr. Richard Sace from the Boston University School of Public Health as our instructor today. And I wanted to let you know that if you'll be tweeting, we're going to be using the Twitter hashtags Lang of Addiction and Opioid Epidemic for this webinar. This webinar is being recorded. The presentation slides and other information from this webinar will be made available to you with the link for the recording. For those of you who are not familiar with the National Library of Medicine, or NLM for short, or its network, NNLM, I've included some background information about both that you will get with the class information. NLM has some very useful online resources and information about health and medical topics. All of the NLM information is available to everyone free of charge. All right, and as far as the schedule for today's webinar, as soon as I finish with some of these housekeeping details, Dr. Sace will be giving his presentation, which will last about 40 minutes. After that, we'll give you about 10 minutes to ask questions. And because we have a large group, we'll use the chat box to ask the questions. And then in the last 5 minutes, I would like to explain an attached document of free resources about opioids and addiction from the National Library of Medicine. And Dr. Sace is happy to share his slides from his presentation, and they will also be included with the link of the recording for this webinar when it is mailed to you. All right, and if this webinar was helpful to you, consider registering for the other webinars in the series. The information is in your packet as well. And the Medical Library Association has approved this each webinar in this series for one continuing ed credit. This webinar hasn't been approved for any other continuing education credits. And in order to receive credit, you must complete an evaluation at the end of this webinar or within 30 days if you're listening to the recording. And at the end of the webinar, there'll be a link and instructions for that webinar. I believe that this health epidemic of opioids and addiction is changing our families and our communities. And I just wanted to add a personal note of why I became interested in creating an educational webinar series about substance use disorder. About 10 years ago, my brother died at age 39 from addiction. And most recently, I have a 28-year-old niece who's now in recovery, but that's after 8 years and 4 times of going through recovery programs. I also have 4 fairly close friends whose children grew up with mine, and those children, some of those children are now battling heroin addiction. And I feel like because I'm, I'm just a regular person, and if my life has been touched in these ways by this disease, I have to believe that I'm not an exception. And I think it's very hard to talk about addiction, especially when it involves your own family. The stigma of this disease causes isolation and really can prevent us from getting the help we need. So I think today's webinar topic about the words we use is a good way to begin to address how we all can stop perpetuating the stigma that is linked to this disease. Oh, sorry about that. There we go. We're back. Okay, so now I would like to introduce Dr. Richard Stace from the Boston University of Public Health. Okay, Richard, you can take it away. So. Sorry about this. One more moment, please. Up, there we go.
Okay. Thank you, Susan, for your introduction, and I appreciate your personal note. We had a brief discussion before our phone call, and it reminded me of what one of my colleagues here at Boston Medical Center talks about when discussing this disease, that it's not a casserole disease. That is that if you have cancer or diabetes or other similar conditions, usually what happens is people knock at your door and bring you a casserole and check and see how you're doing. And when you have addiction in your family, that doesn't happen so much. It's looked at differently and thought of differently, and I think a lot of that has to do with the words that we use. And that's why I'm going to be talking today about misperceptions and the misused language of addiction, the idea that words matter, as I think they do. So I've been doing this for a while. That is, I've been thinking about words and about addiction for some time, both as a clinician, as a researcher, and as someone who writes a lot about addiction. I currently edit the Journal of Addiction Medicine, which is the journal of the American Society of Addiction Medicine, and edit their flagship textbook, among some other publications that I've put here on this slide. If I have a bias, it's that I believe word choice is important, and I'll discuss through this presentation why that is. So what I'm going to tell you is that there's a spectrum of alcohol and drug use and disorders, that some alcohol and drug use increases risks to health. That is, it has health risks, but isn't necessarily a disease or condition. Not all substance use is a disease. But substance use disorders are health conditions. There's a spectrum of use and consequences, and distinctions between these matter. We talk about and address alcohol and drugs differently from other health risks and conditions. And I think those are related. The language that we use contributes to and reflects stigma, and it affects policy and care, treatment choices, and the way that we address this in society. But consensus is emerging around accurate, non-stigmatizing terminology. And I'll summarize at least my view of preferred and non-preferred terms on the last slide of this presentation that'll be available to you. Now, there are other risk factors and diseases out there, and how we handle them is different. We understand that nutrition, that eating, let's say, meat or saturated fats or not doing physical activity is a risk factor for some other diseases. And we address those risk factors in a way that recognizes that they're risk factors for those diseases. We might address those risk factors with medications, let's say for cholesterol, or counseling for diet or nutrition, as well as social messaging. We do all the things that we know are proven to work. And that's for the risk factor side. And for diseases, here's how we handle them. This is the hospital where I work at Boston Medical Center, and when there's an illness, someone with an illness shows up at this medical setting, and they don't have to find a specific treatment provider who's going to give them a specific type of treatment. They come and they see a health professional who assesses the situation, treats it with the best proven treatments for that person at that place and time, right there in that system, not somewhere else. Imagine if you showed up at a hospital and you had heart disease, and they said that they didn't really offer medication treatment for heart disease, or that they only offered surgery and not medications, or that they chose to use counseling for that heart disease. That would be puzzling and surprising, and you'd feel confused about where am I supposed to get the right treatment. And that we handle addiction certainly differently. Here are some ways that we do that. We assume that it's a choice to use substances, and so we outlaw them, and we tell people to make different choices. Now, certainly making drugs less accessible can help reduce use. I'm not arguing that, but it isn't as simple as making a choice. And let's make a few more observations here. What happens to people with diabetes who are incarcerated? Well, they have their insulin continued. What happens to pregnant women with diabetes? Well, they and their babies receive pre- and postnatal care. What happens to pregnant women who drink alcohol and smoke cigarettes? Well, their babies receive pre- and postnatal care. And in that example, I've specifically chosen substance use that isn't as stigmatized as some other substances. But what happens with, let's say, opioid addiction? Well, this was a study that was published in The Lancet, done in Rhode Island, where people who were taking methadone as medical treatment for their addiction and then were incarcerated. That wasn't the study. The study was, well, what happens next? And the researchers compared forced withdrawal from their methadone treatment, that is stopping it suddenly or quickly, versus continuing it while the person remained incarcerated. And when this study was published internationally in The Lancet, one of the commentators raised the question as to whether forced withdrawal was cruel and unusual punishment. The reason it was tested in this study was that it was actually standard treatment and remains the way that people are approached in a standard way in the United States right now in many situations when they're incarcerated. Of course, they found that outcomes were better in people who had their treatment continued, but this is what's going on. In Alabama in 2006, law put in place to prosecute and punish women who give birth to babies with drugs in their systems, not managed or treated as a health condition. So we address this in very different ways. And I think part of that has to do with stigma. Why is addiction addressed so differently? And note that in the examples I gave, it's addressed differently for opioids than it is for tobacco and alcohol. And I think part of the reason is stigma. I'll make that case. One prominent blogger, Bill White, has even suggested that many in our own field, those who focus on addiction, intentionally or not, may be serving to maintain this stigma. It may involve people in the media with words that are used. It may involve the criminal justice settings, child welfare system, even the pharmaceutical industry, and even our very own specialty sector addiction treatment, who are really quite separate from the rest of healthcare. I won't lay out all of his arguments here, but it is something certainly worth thinking about. Now, these recent books, and one more that's not on the slide that I can recommend by Nick Heather called Addiction and Choice, have been controversial. And as with much discussion about addiction, they've been viewed as extreme and one-sided. They suggest and they frame addiction as a choice, and not as a disease. Now, clearly, addiction is a health condition. It has a genetic basis. It has measurable signs and symptoms. It's affected by the environment and social factors like other diseases, and it responds to medical treatments just like diabetes and heart disease. But we do have to admit and recognize that the analogy isn't perfect. Some diseases, let's say glioblastoma, a brain tumor, seems entirely biological and completely out of the control or effect of some social factors, not at all affected by behavior, and that may be true. But many diseases, and most chronic diseases are affected by social factors and choices that people make. And addiction clearly involves choice, but perhaps a disordered choice. And let's look at a few studies then that are germane to this discussion. Probably one of the most famous ones that gets brought up in this discussion was done by Bruce Alexander, psychologist, experimental psychologist. And he did a rat experiment. It's really important. And what he found was that if you give drugs, in this case opioids, to rats in an experimental setting, they use them until they die. In lieu of eating, in lieu of any other activities, they continue to take in morphine in this case. But one thing that I want to point out on this slide before we move to the next one is where experimental rats live. And they live in what don't look like particularly pleasant circumstances. This is a standard housing, a Skinner box. They're isolated, they're alone in that box. And sometimes for experiments they get foot shocks through the floors there, and there are these metal cages, not particularly pleasant. So Dr. Alexander decided to design Rat Park, as it later became called, where the rats are with other rats and in a nice social environment, and they have things that look like trees, and they can wander around and play and exercise. And what he did was he compared rats in standard cages to those who lived in Rat Park. And they were all given a choice to consume morphine or not. And the caged rats consumed much more morphine than the Rat Park rats. The caged rats, you can see it's the solid lines on the top. The Rat Park rats are the dashed lines on the bottom. They consumed very little morphine. And so this suggests that even compulsive use might be just a choice in response to an environment rather than an inherent disease. And if you just leave it at that, you might be misled because there's more to the story, but it's certainly interesting to note that the environment can have such an influence on a health condition. Now, another relevant experiment suggests that for some environment plays a big role and choice, but for others it doesn't. And these were studies done by Lee Robbins and colleagues years ago in U.S. soldiers who were in Vietnam. And in Vietnam, under awful circumstances, they were using heroin frequently. And 8 to 10 months later, when they were home, and these were people who were using heroin multiple times a day by injection, of those doing that, fewer than 10% had a current disorder 8 to 10 months later when they were back in the U.S. That's without treatment. And 2/3 of them were not using at all. So how could that possibly be a disease? On the other hand, think about the comparison in this study. The comparison in this study was adults who were in the United States during that same time period who suffered from addiction and went to seek hospital treatment. And 6 months after that hospital treatment for addiction, 70% of them still met criteria for addiction, and only 10% of them were not using. So how can this be? How can it be so different? And what this suggests to me and to others is that, yes, sometimes use under certain circumstances can become compulsive, but when the circumstances are improved, people can actually improve on their own. But others perhaps have more genetic loading, more biological cause of their illness, or more effect of drug use over time affecting their ability to choose and their motivation systems in their brains, simply cannot stop on their own and need something else. So it just suggests that addiction is complicated, just like many other health conditions. In national population-based surveys, these sorts of data are also used to inform the discussion, and this suggests that the disease can wax and wane. So in national surveys, we find that of adults who have alcohol dependence, and this was using DSM-4, Diagnostic and Statistical Manual of Mental Disorders, 4th edition diagnosis of dependence. In those who have it prior to last year, only 25% continue to meet criteria in that subsequent year, that is in this past year. And only a quarter of those people had gotten any treatment. So basically it suggests that some people can get better on their own. And so motivation and choice certainly do play a role, but this doesn't mean that there's no underlying relevant biology, susceptibility, or illness. And so this slide suggests that there's something more than just a habit. It's not just like, sorry, it didn't come up yet. There it is. It's not just like the habit of tying your shoe that we can all do without thinking and that we could easily stop tying our shoes every day. Biology is clearly involved, and it's the reward pathway, and the reward pathway is essential for human survival, and food and sex activate it, and both elevate dopamine levels in the brain and the pleasure pathway, and we feel pleasure. But drugs do this more so, and you can see all of these slides actually are on, they're on different scales. And the amphetamine slide is on a completely separate scale because it blows the others out of the water. It elevates dopamine levels much, much, much more than food, sex, or even some other drugs. The other drugs also elevate dopamine levels to a similar level of as sex and even more. But these are in a system that's fundamental to our survival, so it's not surprising that when we're exposed to a substance that overwhelms the system so much that it might even affect our later choice to use them. And that may make that choice disordered. And use over time may further disorder that choice, if I can use disorder as a verb. So what about choice? Well, first of all, not all use of substances is a disease. We talked about that. And not all substance use disorders are the same. And everybody who's ever met anyone who really suffers from addiction knows that nobody would choose to be in that circumstance. So it can't simply be a choice. And even if the first use is a choice, repeated use leads to brain changes that reduce the capacity to stop. And we already know that there are multifactorial genetic and environmental etiologies. And frankly, we treat the consequences of other choices too, so it should be no different here. We do bypass surgery, even repeated coronary artery bypass surgery for smoking-related diseases, and smoking is an addiction too, and yet that's viewed somehow differently. It's talked about differently. And I think the case I've been making and putting on the slide is that substance use and addiction, substance use disorders are not all one thing. Just like heart disease and other complex conditions are not all one thing. We have ways to define this, and this gets into the terms that I think the kinds of terms that I think that we ought to be using. So we can define substance use disorder or addiction. And in this case, I've put up the definition for alcohol use disorder that comes from DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, the 5th or current edition that came out in 2013. And that defines the disorder by whether people meet 2, 3, 4, 5, or 6 or more of the criteria that are listed here, of the 11 criteria. For those of you who have been in the field for longer or are more familiar with diagnostic terms, those who have a moderate disorder, that is 4 or more of these symptoms, it's more like what used to be called dependence in the earlier edition of DSM. And it's also similar to what's called dependence internationally. I do apologize that there are lots of terms and the terms vary internationally. It's just where we are. But the DSM-5 does define a disorder, and the disease or the disorder or the health condition is called substance use disorder, or in this case, alcohol use disorder or opioid use disorder. And when referring to that disease, that's what we should call it. But there is a spectrum, as I mentioned before, of use. And this triangle suggests that what we're interested in for health purposes appears in the orange triangle, which I'll call unhealthy use. And that's any use that is of relevance, most use that's of relevance to health. And it ranges from, at the tip of that triangle, where I've written moderate to severe, in this case alcohol use disorder, but it could be substance use disorder. That's at the tip of the triangle of severity, where there's more use and more consequences. And as you go down the triangle, the next category down in DSM language would be mild use disorder. So you've got moderate to severe use disorder, then mild use disorder. But then in the more orange part of the triangle, towards the bottom, towards the middle of this larger triangle, but towards the bottom of the unhealthy use triangle, you see risky use or at-risk use. And those are people who are using substances but don't meet criteria for a disorder. They may, in fact, not have a health condition or a disease, but they're at risk. For example, to put it at one end of the spectrum, we know that for women, 1 to 6 drinks, standard drinks of alcohol per week increases the risk of breast cancer. So that's risky use of alcohol. That's not an alcohol use disorder. But use, along with meeting the criteria that I showed on the previous slide, would be the disorder. So those are different things. And they may differ by substance, too. So we know that even one use of cocaine might lead to ventricular fibrillation and sudden death. So a use of cocaine could be risky use even without having a disorder. So this is what I think of as the spectrum of unhealthy use, and it's not all one thing. It's not always a disease or a disorder. Sometimes it's use that risks health consequences. So this is what I would suggest for the terminology for that spectrum. And now you can see that there's much less on this slide. So for use that risks health consequences, I would suggest using at-risk use or risky use. Some internationally have advocated for the term hazardous use. I think these are all fine to denote use with a risk of consequences. Then there's, for the disease, in the U.S., we tend to use DSM terms, and so that would be use disorder, opioid use disorder, alcohol use disorder, cocaine use disorder, substance use disorder, if you don't want to specify. The American Society of Addiction Medicine has defined addiction, and that often, the definition includes use that's really, that's out of control, compulsive use, and it talks about it being a brain disorder. I don't know that all substance use disorder is a brain disease. If you think back to the 11 items in the DSM that I listed for you, you could imagine that some people might meet 1 or 2 of those criteria. If they met 2, they would have the disorder, and I'm not so convinced that that would be a brain disease. But certainly, there are some people who have substantial brain changes, and those brain changes are likely associated with the recurrence or continued manifestations of the disease, and that's probably where the term addiction applies more. The reason that I'm hedging a little bit, and it may sound that I'm like I'm hedging, is because there aren't criteria specified to make the diagnosis of addiction. So there's a wonderful description. You can go to the ASAM website at asam.org, and you can see what the definition of addiction is. It's been published. But it's a little bit more difficult to apply clinically because there aren't operational criteria, which there are for the DSM. But it's certainly a fine term, and I should tell you that when the DSM, when the committee that wrote the DSM book decided to call it use disorder, there was actually disagreement about whether to call it addiction or use disorder. So at least in the minds of the writers of the DSM, they were thinking of using addiction and use disorder interchangeably. Certainly they're both acceptable terms. Now, internationally, the terms used for the diseases are dependence and harmful use. So they've chosen to use 2 terms, one for the more severe, that's dependence, and one for less severe, harmful. Those 2 terms map a little bit closely, fairly closely, to the way that we used to call it in the DSM before 2013, when we used the terms abuse and dependence. We no longer use the diagnostic term abuse or dependence, and there are good reasons for that, some of which I'll mention later, but they are still used internationally in the International Classification of Diseases, and people using ICD-10 codes to diagnose clinical visits may be using those terms, and so you can be aware of those as well, and they have their own definitions. But dependence and harmful, if you were to combine dependence and harmful use under the ICD, it would be similar to use disorder under DSM. All the terms on this slide would be reasonable to use and are medical, accurate medical terms that can be used. Now, stigmatizing terms can affect perception and behavior, and this is why I care about this, and why I think we should all care about this, of patients, their loved ones, the general public, scientists, and clinicians. And it can also affect the quality of care and health policies. That's one reason that we want to use medical accurate terms. Another reason is that there can just be confusion. And dependence is confusing because if you use the word dependence, I don't know if you're talking about the DSM-4 defined disease or the ICD defined disease, or if you're talking about physical or physiological dependence to a substance. If I prescribe for you a hypertension medication like a beta blocker and I stop it suddenly, you will have manifestations of physical dependence. That's certainly not addiction or substance use disorder. And those two things are different. And in fact, they're often confused, and this is why the DSM went away from using the term dependence. So I would suggest restricting the term dependence to only when you're talking about physical and to actually be specific about that when you use it. An example of where this has had terrible consequences has been in the mislabeling of infants with addiction. And this was actually a paper that came out in the Journal of the American Medical Association, and full disclosure, I'm now an associate editor for this journal. When I saw this come across my email on April 27th at 10 a.m., I immediately called them and we got it changed. But here it talks about opioid-addicted infants. And the issue here is that infants cannot have addiction because they can't use compulsively because they simply can't do that. They could be physically dependent on an opioid, but they can't suffer from addiction. And so this was later in the day, by 4 p.m. that day, it was changed in the title of this particular paper to neonatal abstinence syndrome. Another term for that might be neonatal withdrawal syndrome. That might be even better because neonates can't decide when to be abstinent or not, but certainly the syndrome is often called that. Now, stigma is moderated by two factors. It's, did the person cause it? Do we think they caused it? Or maybe it's not their fault. And do they have any control over it? Can they help it? They can't help it. So if we perceive that it's not their fault or that they can't help it, we are more compassionate. That decreases stigma. Now, how does this relate to substance use disorders? Well, there are two commonly used terms to refer to people with substance use disorders, and they're disease-first terms versus person-first terms. So referring to someone as a substance abuser implies willful misconduct, like it's their fault, that they could help it, right? If we refer to them as suffering from or having a substance use disorder, this implies a medical malfunction, right? It's not their fault, they can't help it. But you could say to me, does it really matter how we refer to people with these highly stigmatized conditions? Can't we just dismiss this as a well-meaning point, but just semantics or political correctness? And I can tell you the answer to that is yes, it does really matter. And one of my colleagues, John Kelly at Mass General Hospital, went to the White House to present the results of his study that he did on this. And it was a vignette study. He basically presented two stories to experienced doctoral level clinicians with experience treating mental health and substance use disorders. And they were randomly assigned to be exposed to two different scenarios. And you don't have to read all the words on this slide. There are two stories about someone who is getting treatment for addiction. And in the first story, you can see the bolded term was substance abuser. He has been a substance abuser. And the second version of the story is identical, but it talks about him having a substance use disorder. And clinicians were randomly assigned, and then they were asked how they would, what they thought about the person and how they would treat and address the condition. And it turns out that how we talk and write about these conditions actually does matter. Counselors who were exposed to the abuse condition, that is where that term was used, agreed more with the notion that the person was personally culpable and they were seen as a social threat, and treatment was less likely to be recommended, and they thought punitive measures should be taken. And so words really do matter. And then look at these examples from how we talk about substance use disorders and people who have them. Methadone maintenance, a treatment that objectively decreases HIV transmission, it decreases mortality, it leads to abstinence from use of illicit opioids, and yet it's still somehow controversial, with people saying things like, I don't believe in methadone, substituting one drug for another, it's liquid handcuffs, and with newspapers using words like addicts. Addicts shoot up in the Mass General Hospital bathrooms. That appeared in the Boston Herald last year. And my least favorite example, or I guess my favorite example, but really an awful example, was back when there was a huge construction project in Boston, and many of the construction workers at what was called the Big Dig, some of the construction workers suffered from opioid use disorder, and they were going as required to get good treatment at a methadone clinic, and they lined up there every morning because that was the only way that they could get their medication treatment for their addiction. And the front page of the Herald, they took a picture, showed it on the front page, and called them Big Dig junkies. Now, these are people who are getting medical treatment for their disorder, the most effective known treatment, and who are trying to get their treatment before they go to work every day. And they were put on the front page like this, which just shows a real misunderstanding that's promulgated by the way that the words that we use. Now, even the director of the National Institute on Drug Abuse, and I will point out that that institute's name has abuse in its title, used the word abuse in the title of an article, Opioid Abuse, and we'll talk a little bit more about that term because I find it it's not only that it's stigmatizing, it's also inaccurate. I'm not really sure what it means in the title here. Did it mean DSM-IV abuse? Did it mean something else? But there's now been a lot of discussion about terms to use, and this appeared on the front page of the Boston Globe, a struggle to rewrite the language of addiction, where journalists were beginning to pay attention to language and how it should be used, which, by the way, resulted in the Associated Press changing their style guide just this year, and I'll get back to that as relevant later. These were some tweets because although the Boston Globe called for using appropriate language, just a few weeks later they published another article that used addicts in the title, and a number of us began tweeting about it. And a reporter lamented that word choice was unclear and complained that a person with substance use disorder or person with addiction was too long, it was too many words. But many of us pointed out that somehow we seem to be able to report on people with cancer without a disease-first word to call them. We call them cancer survivors or people with cancer or people who suffer with cancer. We don't have an equivalent of addict for person with cancer. And somehow we're able to write newspaper stories about that. So this is really what I think substance abuse, this is probably the most appropriate use of substance abuse. You have a substance that's being hammered with a hammer, but we should probably avoid this term not only because it's stigmatizing, but because it's inaccurate. I don't know what people mean when they say it. And we've actually gotten widespread international agreement that stigmatizing terms, particularly abuse, ought to be avoided. The International Society of Addiction Journal Editors has published a statement that they agreed on internationally, saying exactly that. And there are a few other terms then that I think come under this category of terms that we should avoid. And John Kelly and Sarah Wakeman and I published this piece in the American Journal of Medicine a couple of years ago, suggesting that people avoid the terms dirty, clean, as well as abuser. When people have diabetes and they come in for a check of their blood sugar, we don't tell them that their blood is dirty. We tell them that their blood glucose is elevated. So we should tell people when we're monitoring their illness, their addiction, that their urine test is negative for drugs. Clean is another one. It seems like a good thing to be proud of, that the person is clean or their urine was clean. But it's quite strange because the person isn't clean or dirty, right? They are either continuing to have symptoms of their substance use disorder or not. And they may have a positive test or they may have a negative test, which is more appropriate and clinical. Other terms that I think about these days, very commonly used term is medication-assisted treatment. This is a strange one because it makes it sound like medications are assisting something rather than simply treating a disease, which they're doing. And we don't use such terms. I'll go back to diabetes as an example. We don't use such terms for other illnesses that also have substantial behavioral components to their treatment. I mean, diabetes, type 2 diabetes, behavioral treatment of type 2 diabetes is a substantial part of that treatment. And yet, we don't feel the need to call a medication for diabetes something other than a medication for diabetes. So calling it something like medication-assisted actually gets in the way of people accessing a known effective treatment because it's thought of as something that might just help, even when it's been shown to decrease mortality, which isn't the case for many other addiction treatments, frankly. Substitution is another mistake. It's not substitution. Opioid agonist treatment like methadone or buprenorphine don't substitute for heroin. They're not very good substitutes for heroin. They don't make people high. They don't cause euphoria. They don't do all the other. They don't produce all the other metabolic derangements that short-acting agents like heroin can produce when used outside of medical supervision. And so, instead, we should just call these medications or treatments or opioid agonist treatment. And even the World Health Organization has now decided that it's not a good idea to use the term substitution anymore. And there's a few references on the slide there calling for that. Now, one leading scientist and addiction expert, Bill Miller, has even called for us to retire another commonly used term, relapse. And it's interesting. And the reason that he calls for us to retire the term relapse is because relapse makes it sound very black and white. And for people with a chronic disorder that waxes and wanes and sometimes has symptoms and sometimes doesn't, relapse is probably not really reflecting what happens for people with these conditions. And it can contribute to mistaken thinking. And this is just an example from Tom McClellan's thinking. Tom McClellan, who was at the Office of National Drug Control Policy in the White House some years ago, and a well-known addiction scientist, he pointed out that usually when we look at treatment for something like a medical condition like hypertension, and we see that during treatment the severity of the condition or blood pressure goes down and improves and we stop treatment, we conclude that the treatment worked, and that not that the person relapsed, that their blood pressure wasn't under control. And so we resume that treatment. When we see that same pattern for addiction on the bottom right hand of the slide, we conclude that the treatment didn't work because we gave somebody treatment and then after treatment they relapsed. So this is where the terminology and where how we think of a chronic condition may come together to contribute to misperceptions. At the Journal of Addiction Medicine, which I edit, we try to aim for recommending authors use humanizing, non-stigmatizing medical scientific terms that are precise and professional consensus driven. And so we provide detail. If you're interested, you can see our detailed instructions to authors. You'll have the link to this. And we recommend person-first language that is not addict, alcoholic, or drunk, but person with whatever the medical condition is they have, like substance use disorder. We avoid the words abuse or abuser. Use is actually usually more accurate. If someone says, he was abusing alcohol, what does that mean? How is that different from he was using alcohol? If you want to specify how much it was, that's fine. Specify how much. The disease, we talked about those terms. I do like to think about whether we should use the word drug or medication. I tend to reserve medication for medications, for things that have a proven benefit and are produced by a company and sold and approved, et cetera, et cetera. Drug might be something else. And I generally avoid misuse, although not all the time. Sometimes I think for prescription drugs it's complicated, and we often end up using the word misuse to distinguish from prescribed use. But I would avoid misuse for when what we really mean is disorder. If it's disorder, let's call it disorder. Now, some would say, well, wait a second. There are many people out there who therapeutically get benefit out of calling themselves a disease-first term. Like if I were to say to you at an Alcoholics Anonymous meeting, hi, my name is Rich and I'm an alcoholic. And is that okay? Sure. My advice has nothing to do with what people want to call themselves. And if people find that helpful, then they can do that, of course. What I'm talking about is the terms that we should use as scientists and clinicians and health professionals when we speak about others. And it may well be that sometime in the future, people will no longer internalize or want to be known as their disease first. But it's certainly okay if people do so and find benefit from that. I'm going to skip this next slide. And there are reasons why it's difficult to change the language that we use in this field. There is, of course, inertia. Sometimes we want to speak quickly and we use what's comfortable, and some of the alternatives may be perceived as cumbersome. And we've got agency names that aren't easy to change. They require an act of Congress, and I think, as we all know, Congress acting is not a simple thing. So the names of an agency like NIDA or SAMHSA, the Substance Abuse and Mental Health Services Administration, single state agencies for substance abuse, names of some highly respected journals like Substance Abuse Society names are all there and difficult to change. But I think we ought to think about changing those because it does make it hard to change words and perception if we don't change those. I have to say I was stunned when we wrote a letter to the editor of a highly respected medical journal and pointed out that they had confused substance use and substance use disorder. And the editor of that journal responded by saying, well, of course we were correct, but that basically that we ought to get over it because it can be very challenging to distinguish between, to distinguish between substance use and substance use disorder. Now imagine if a journal editor had written back that it was really challenging to distinguish between an elevated cholesterol and a heart attack. Like it's very confusing. I don't think we can be in a world where such things so easily get confused. And neither do many leaders now who have written widely about changing the language of addiction. If you haven't seen it, you should look for Michael Botticelli and Howard Koh's piece in the Journal of the American Medical Association from last fall. And you can, I'll let you read that on your own, but there's a lot of consensus that's developing. Much progress is being made. And you can look at the letter on this memo from the Executive Office of the President. Look at the date on this, which is January 9th, which of course is before the 20th, so it's not clear how this is being or will be implemented. But Michael Botticelli, who was in the Office of National Drug Control Policy at the time, was able to get a memo out basically telling the federal agencies that they ought to use accurate, non-stigmatizing terms, just like I'm recommending to you today. And despite the agency names, he was requiring that of across federal agencies. It's really an impressive document that still you can find online. So what I think I told you is that alcohol and drug use have health risks. They're not just disorders and diseases, but sometimes they are. And we ought to be accurate in our terminology to distinguish between when we're talking about use versus when we're talking about a disorder. These are health risks and health conditions. They're not identical to 100% biological conditions, but plenty of diseases are not 100% biological. And there is this spectrum of use, and consequences in these distinctions matter. We talk about and address alcohol and drugs differently from other health risks and conditions, and we shouldn't do that because how we address them is related to how we talk about them. Language contributes to and reflects stigma, and it affects policy and care. There really is consensus emerging now around accurate and non-stigmatizing terminology. And as I promised in the last slide, I'll just list terms that I think there's general consensus around. There may be some argument around some of these. There's always going to be argument, and I think in this field, terms are going to change over time, and we just have to be aware of that and ready for it. But on the left-hand side, I've listed the terms that I think I've suggested during this talk that we use, like use disorder and addiction and person with, that is person-first terminology, treatment, positive and negative tests rather than clean and dirty, unhealthy use as the spectrum, risky use as use that increases health consequences as opposed to abuse of a drug or alcohol, and really trying to especially avoid abuse, abuser, addict, clean, dirty, and the like. So I'll stop there, and I'm happy to take questions however that works. Thank you.
All right. If you have questions, would you like to put them in the chat box? Dr. Sayce, how did you get interested in this topic?
Yeah, I mean, I got interested in this topic because I noticed that there's a major health condition, one of the leading causes of preventable death in the U.S. and in the world, that doesn't seem to be addressed similarly to others. And I realized that that has a lot to do with how we all view it, and that the words that we use have a lot to do with that. And when wanting to do research and take care of patients in areas like this, I found that there's a lot of inaccurate description of folks with these conditions, and you really can't get anywhere unless you know what the condition is that you're talking about and can refer to it appropriately. So it's really been part of my whole career ever since I decided to focus in this area.
Okay. We have one question. I don't know if you can see this. Curious to know your thoughts on ACE's Adverse Childhood Experiences idea from Dr. Sumrock, ritualized, compulsive, comfort-seeking term for addiction.
I'm not sure I understand the question, and I can't seem to see the question. Oh, wait, there it is.
Okay, we just added it to the chat box.
Yeah, okay. Let's, I guess I'm still not sure that I understand the question. I don't have an opinion about the term adverse childhood experiences.
Yes, I was going to say if the person could maybe explain that a little bit more for us, but we'll take a second question. We just put it in the chat box. Has there, wait a minute.
Right, I see the question is, has there been any interest involving the social work community in developing more humane terminology? I mean, honestly, I haven't seen any particular profession taking or not taking responsibility for the terminology, but certainly all health professionals that address these terms have, or that address addiction have contributed to the discussion. I believe Michael, I'm not sure now. I don't want to speak out of turn. I thought Michael Botticelli, who worked on these terms and did a lot of work on them, is social work trained, but I could be wrong about that, so don't quote me on that. But certainly scientists and physicians and clinicians, social workers, psychologists, counselors, and many others have contributed to this. So I guess the answer is, of course there's interest in involving the social work community in developing more humane terminology. One surprise to me as a physician myself, and initially, and still am, an internist focused. You might think that I'm more focused on such biological things. I always thought that this was in the purview of social work and psychiatry and psychology, and I was shocked to find out that many social workers, psychologists, and psychiatrists are not trained in addiction. I think that's getting better, but just like other health professions, it's only a subset of each profession that has some specialized knowledge about addiction. I see another question that says, we do a lot of training and education about stigma in our community. How do you address the fact that many people who stigmatize addiction may have experienced negative consequences? That's an excellent question, superb question. It's absolutely true that we should not ignore the fact that sometimes people with addiction commit crimes, and they might even hurt us emotionally in our families. We may be very hurt by them. We may be hurt by random violence related to purchasing drugs illegally, et cetera. So absolutely, we have to address that reality, and that is different from, we should have to admit that, and that's different from many other conditions. We wouldn't normally think about diabetes as being related to those things. We might think about other diseases, either psychiatric illnesses or other brain-affected diseases like Alzheimer's disease, as causing some similar struggles in families. And so I guess the way that I think about that is certainly not everybody with addiction commits crimes or has these sorts of interactions in their families. Some do, and some don't. But I think in order to really talk about this as a health condition, we do have to recognize that that sometimes there are these external consequences that come along with the illness. So we have to recognize that. But I think simply that doesn't make it not a health condition, I guess, is the response that I have to that. There's another question that says, I saw that researcher medical professionals' responses were studied. Has there been a study in how those with the disorders have responded to the terminology? Again, an excellent question. If anybody listening knows about such a study, please send it to me because I'm not familiar with one. Although, sort of anecdotally, as I said, it's pretty well known that often people do like to call themselves by the condition first, like, hi, I'm Rich, I'm an alcoholic. The closest that I can come to in answering that question with a study is that it has been studied that requiring people with the condition to accept a label, like requiring them to say that they agree that they are an alcoholic, is not required for treatment. In fact, for treatment to be successful, in fact, in such study, people have been less successful at treatment if they've been forced to accept a label when they don't want to. So, I guess the way I would look at this is making people use a disease-first term for themselves is not a good idea, and that we have some evidence about that. But if people so choose, I don't know that we have any evidence that shows that that's particularly bad for them, and for some, I think it's thought to even be therapeutic. Last question there is, people with a history of SUD are often SUD clinicians who are working in a segregated system of care where stigmatizing terms are the norm. How can we better address this challenge? Another question which I love. I think that we will have a very hard time addressing that challenge if we insist on keeping substance use disorder treatment separate from the rest of all healthcare. And so the solution, this is going to take a while, it's not something that can be done easily overnight, but trying to continue to have this dichotomy where we completely separate treatment for substance use disorders from the rest of health and health care is a huge mistake, and it does exactly what this questioner is talking about, that it keeps the whole system and the clinicians and the people with the disorder separate, and whenever they're separate, you know that it's not equal. So if this is a health condition, which I certainly think it is, and there's tons of evidence for, then it should be treated like a health condition, and it should be treated in our healthcare system in an integrated fashion. And until we do that, as long as we maintain these separate systems, we're going to have separation and inequality and disparity. There is a comment. There is a quick comment there just about how this is similar to other mental disorders. And I certainly agree that there may be this sort of self-stigmatization may, for some people, not be so therapeutic, and that may happen for people with mental health and substance use conditions, but certainly an area for study. Thank you, Susan.
Okay. You know what, there was one last question. I don't know if you saw it. Our first responders are burning out repeat Narcan patients sometimes in one night. Any good resources to suggest?
I think that's really going to be beyond the scope. However, I will make the observation that people with asthma keep coming into the hospital all the time with an asthma exacerbation, and with diabetes, because they may not be taking their medication, they relapse and they end up in the emergency department. It really doesn't feel all that different. Although I do get the sentiment being raised by the questioner, especially if you see somebody twice in one night. The short answer to people who have their overdoses reversed and then go out and overdose again and then come back is there's a huge failure of our treatment system and our healthcare system for that person, right? That person ought to have been linked immediately to treatment, not been given a list of resources to call and to try to get an appointment and an assessment a month later. That person should have been started on treatment immediately. And part of the reason why they're not is because the system is so separate from the rest of our healthcare system. So that's a short answer.
Great. Okay, everyone, we do have to end this. Dr. Sayce, thank you so much for this presentation. You know, it really has caused me to think about the words I say instead of just saying them. Everyone, I will email you out the link to the evaluation, and I think that's it. All right.
Thank you very much.
Goodbye, everyone.
Appreciate it. Okay, bye-bye.